Welcome everyone. Thanks for joining again. We have now Mr. Maxime Vala. He is a consultant from Harlow, and he is an excellent FRCS teacher and educator. I think most of you will know him from various courses and events. He's gonna present us tonight one of his lectures about genetics and orthopedic related to trauma and orthopedics. And please pay attention to it and use the chat option to put any questions that you have or any comments to him, and make the best use of his knowledge, please. We have also Shwan. He's also with us, and he can step in if there's if you have any questions to him that you like. Okay, I'll put it over to Mr. Maxime Vala.
Yeah. Thank you, Firas. Thank you, Shwan. What I'll do is I'll go on to share screen, and Firas, will my picture be also coming, or will be only the
only mainly the share screen will be?
Only the PowerPoint will be coming up. Is that correct?
Yeah.
Okay. So before we start, then, this is a topic I know Shwan has done embryology. I think Firas, Shwan, and me we had a discussion, and maybe for some topics like this, rather than having it like a hot seat viva, maybe we'll do it more like a presentation with less questions. Is that all right by you, Shwan and Firas, to do it by that topic?
Yes.
Just so that it's a difficult topic. If information can go across to say it like this, it just helps them to study better. Is that all right?
Yes, please.
So let's start on okay. So can we come on to genetics?
Yes, please.
Yeah, we'll start with that. Just a minute. Now, let's start with genetics. Is a difficult topic. It's difficult because we don't discuss this in the coffee room. And the topics, but unfortunately, it's part of our curriculum. It's going to be asked in basic science fiber. Just the plan of today, diseases and patterns and definitions. So I think this is the only important thing, that whatever the questions we're going to be asked will come under this first part, which is disease patterns and definition. Then there may be some classic genetic conditions like osteogenesis imperfecta, achondroplasia, etc. So just imagine this. Can you put this out, Firas, is one question. What do you think are the common scenarios you may be asked in this question in the genetics? Firas, can you just ask anyone just to begin with?
Okay, so I think you all heard this question from Mr. Maxime Vala. What are your understanding of how can genetics pop in the FRCS exam? Anyone want to answer that question? Raise your hand, please. We have Muhammad. Okay, Muhammad, go ahead.
Hello.
Yes, Muhammad, you can go ahead.
Hi. I mean, basically, it can be asked in a clinical scenario, or in that a patient comes, female patient with a Dupuytren contracture, for example, and she's worried that she heard that her kids can get the condition.
Very correct. So
and
that's
she wants to know the likelihood of them developing this condition.
Okay. Anything else?
It can come as well into the which type of defect in genetic that this is happening. Is it chromosomal defect?
Correct. Exactly. Very correct. So you're right. I think the common scenario will be there's a mother and a child, and the mother's worried about any conditions. Excellent. And the second would be a photograph, a clinical photograph of a child with achondroplasia, Downs, etc. And you have to know the exact classification of that. Third will be a chromosome. A photograph of a chromosome will be shown to you. Is that correct? And fourth will be a DNA. Right? So these are more or less what we will cover. So just to know, the first thing just to know, just remember the genotype is your individual's genetic composition. Okay? And a phenotype will be the environment observed effect on the individual. So environment, when environment is involved, it becomes the phenotype. Okay, so let's move on. Let's imagine we have this photograph on your right. So you're going to say this is a chromosome.
Mr. Maximavala, can I just say, we can't see your presentation at the moment. We're only seeing a list of PowerPoint presentations. We can't see your actual presentation.
Okay, sorry. Then I'll start again. Can you see it now?
Yes, we can see it now. Perfect. Thank you.
Can you see it now?
Yes, we can see it now. Yes, thank you.
Yeah, okay. So this is a chromosome on the right. So you tell the examiner, this is a photograph of a chromosome. It is seen during cell division. That's why you have a centromere. We divide it into two arms, the P and the Q. And it's either submetacentric or not, okay? And then say you have the DNA. And the DNA, we all know how to describe it. Now in DNA, just remember there are three definitions which you should know. One is replication, second is transcription, and third is translation. So rather than asking anyone, just very simply, replication is the process of DNA synthesis, where each DNA orchestrates the synthesis of daughter DNA. So exactly the same genetic information is passed on. So keep things very simple. I've said it in this manner. Either say it in the same manner or write it in the same manner so you can reproduce it in your words. Please understand, you can go on reading this, but unless you say it yourself, it won't come out. Transcription, remember, C comes before L or A. So transcription is before translation. So you can just say very simply, transcription is the transfer of genetic information from DNA to RNA. And then say translation is a transfer of genetic information from the RNA to a protein. Right? So keep things simple so it comes out. Just remember, there's something called homozygous, there's something called heterozygous. Homozygous is two identical alleles, and heterozygous is two different. So simple to remember, nothing more complicated than this. Just remember, I'm introducing this. It can come here, it will come in statistics. And this is, I feel, one of the simplest definition. Incidence is the number affected per 1,000 births. And prevalence will be the proportion of the population affected at any one time per 1,000. Okay, so just remember incidence, number affected per 1,000 births. Now, the next slide is something which will cover 90% of your confusion in genetics. And one of the questions which Shwan, Firas, and me would probably find when we ask any candidate to describe a condition, everyone will start talking about autosomal dominant or recessive, and that's not really the case. So this slide is such that all problems or genetics are classified into, first will be chromosomal abnormalities. And that is the rarest, is 3.2 per 1,000. Just remember that. And these are abnormalities of the chromosome. Okay, so bang, something's happened and there's abnormality of the chromosome. The second, remember the big classification is single gene inherited defect. Just remember this word. That's 7 per 1,000. And third would be congenital malformations. And remember the word multifactorial or polygenic. And that's 30 per thousand. So I'll just repeat again because I don't mind spending as long on this slide. The first classification you need to know about is chromosomal abnormalities, 3 per thousand. Second is single gene inherited defects. And third is congenital. Let's go further into each one. In chromosomal abnormalities, remember, it can be due to structure, just divided in your mind. It can be due to structure or it can be due to number. If it's due to structure, it's deletions which are lethal. Otherwise, you have just inversions or translocations. Just remember these words. But the more common ones we see are of number. And that would be, the classical one is trisomy, Downs, we'll remember that. Remember, if we have one less, XO, we call it Turner's. And you have an extra, we call it Klinefelter's. All right, so very simple. These are all chromosomal abnormalities of number. Next, these are conditions which are called single gene inherited defects, which means scientists have realized that there's one gene which is responsible for an orthopedic or a genetic condition, and that gene is passed down in a particular manner. And this is the classification where all the things like autosomal dominant, autosomal recessive, X-linked dominant come in, okay? And now for that, and the third one, so remember this is the second one, and the third big classification is use the word multifactorial, use the word polygenic, use the word familial clustering, and which orthopedic conditions come under this are the commonest ones are club foot, that's CTEV, and DDH. Now, Swan and Firas, you want to contribute anything so far, or should I carry on?
I think we would like you to carry on. I think you.
Okay. Is it clear so far from what we've said so far from the presentation? At least you're seeing the screen all right.
It can't be any more clear. It's very, very well nicely described and very precise.
Thank you.
It will be recorded so other people of the group can view it at their leisure later on and review it again.
Excellent. So now, remember the candidate who came up very rightfully said that, he needs to know what is the risk factor of a child having a condition. So can we just ask anyone, Firaz, just one question? The question is going to be that you're in a clinic and there's a mother who's sitting there with her daughter who is 7 years old, who has CTEV, right? Congenital talipes equinovarus. And the question the mother's asking me is, I'm pregnant now and I'm worried about my next child having CTEV. So please tell me, how will you start counseling this patient? So put it to anyone, Firas.
Okay, guys, who would like to describe how you counsel this patient with the CETV? Muhammad, go ahead. Muhammad will go ahead, but next time I will pick someone else.
Sure.
So I explained to the mother that the club foot is congenital malformation, which is multifactorial.
Mm-hmm.
And that means it does not follow the classical inheritance pattern.
Very good.
In that case, there will be risk factor which would increase the likelihood of it being present or happening to a child.
Mm-hmm.
But I cannot give her exact figures.
Okay. Any points which may give you, so therefore you're very right. So please, so in this condition, use my classification or the classification and say this condition comes under the polygenic or the multifactorial.
Multifactorial, yeah.
Yeah. Imagine if I had said, given the same scenario for a child with Down syndrome, you're going to say this comes under the classification of chromosomal abnormality.
Chromosomal, yeah.
Now, in this condition of club of CTEV, I'm going to introduce this. So this is called a bell-shaped curve. You agree? And
Yeah.
we want everyone to be within over here. It's called regression to the mean. Is that correct?
Yeah.
Now, we don't want the next child, unfortunately, to be here having the condition. So the risk, we have to know what is the risk factor for that. So keep this in mind. The risk is greatest among the first degree relatives. So the closer you are to the brother and sister is higher rather than someone saying my cousin has it. Okay. Second is that if this child, unfortunately, who is already born, the 7-year-old, has a very severe form of that condition, then unfortunately, there's a higher chance of the next child having it. So the more severe the condition, the higher the chance of the next child having it. And third, we all agree PPV is common in boys, is that right?
Yeah.
And therefore, this is the daughter having it. So if the rarer sex has the condition, then unfortunately, there's a higher chance of the next child being in this area. Clear? So I've just given you a little flavor of how to talk about this question of genetic counseling, right? If you had a question which covered something like achondroplasia, then the counseling would go according to a single gene inherited defect, and you'll start talking about how the inheritance pattern is. So now let's move on. Thank you, Mohammed. Very good. So I'm moving on to just the second part. Remember, we talked about this. This is the single gene inherited defect. And in this, remember, we have two conditions. We have the dominant condition and the recessive condition. And now let's start with the first one. Autosomal dominant inheritance. Common conditions, osteogenesis imperfecta and neurofibromatosis. Few points, just remember, okay? The affected person is heterozygous, males and females equally affected. And in every generation, you have this. So 1 or 2 points, write it down yourself and try to memorize that. I don't think you will be in a position where you have to truly draw your diagrams, but you must be able to at least be in a position to know what that is about when you're drawing an autosomal dominant condition. Okay, so I've got it here for you. Next will be autosomal recessive. So in that, common ones are Hurlers and the mucopolysaccharide disorders. Remember, males and females, and the carriers are the healthy parents. Okay, so remember 1 or 2 points on these. Once again, you need to know a bit, and I've put this here for you. Third would be X-linked recessive. An example is Duchenne's. And male-to-male transmission cannot occur. So just remember 1 point or 2 points of every one of these conditions which you can reproduce. And third is the X-linked dominant. A good example is vitamin D recessive rickets. And the one line on that. I just want to recap so you don't get confused. Let's start again. Autosomal dominant is the first one. Common examples are osteogenesis imperfecta, neurofibromatosis, males and females, and there's an affected individual in every generation. In autosomal recessive, good examples are Hurlers, mucopolysaccharide disorders, males and females, and the carriers are the healthy parents. Then we have the X-linked recessive, Duchenne's muscular dystrophy. Male-to-male transmission cannot occur, so remember that. And then we have the X-linked dominant, which is vitamin D resistant rickets. So now we've covered DNA, we've covered chromosomes. So you're going to be very happy if a chromosome picture comes to you, you're going to start with chromosomes. If the DNA comes to you, you're going to start with DNA, replication, transcription, translation. If there's a question on counseling, you know first to classify as to where it lies in these three, and then give the answer about how badly it's going to be affected or not. Then we talked about all the conditions of single gene inherited defects. And now imagine that now the options left are that you will be just shown a picture of someone with a certain vector. So you're going to say this is a vector. It is an autosomal dominant condition, which I do know is a single gene inherited defect. Say the scientists know the gene, and there's a classical mode and method of inheritance. You can say coli A1 encodes the protein chain. So you know a bit about which gene we are talking about. This is a classification. All of you all know it. So just remember it so that you're going to say it when it comes up as a picture of that child or the adult. Just another example we put to you is achondroplasia. Once again, how are you going to start? You can say, yes, this is a picture of an adult or with achondroplasia. Tell them, I do know it's an autosomal dominant condition. Say it comes under the classification of a single gene inherited defect, which means we know that it's a single gene, and we know that gene is the fibroblast growth factor receptor 3, which is affected. Then you can say there's a classical mode of inheritance, which is the autosomal dominant mode of inheritance. And then you need to know some orthopedic features of that condition. So you can say there's mid-place hyperplasia. What else is there? Can you, Firas, Shwan, can you just ask someone who's
we have
manifestations of achondroplasia?
But we have Athar who would like to take part.
Yeah.
1 minute, please. Athar, can you answer the question about other manifestations of achondroplasia, orthopedic manifestations?
Orthopedic manifestation, how we see achondroplasia is they are short, they have got neck problems, and they have got spine problems. Okay. Once we need to establish, after looking at them, that whether they have any rhizolemic or mesomelic limb shortening, and with achondroplasia, it's rhizomelic. Then we look into their pedicles on their spine because they come with scoliosis, and you look for the scoliosis. And then you have the facial features of achondroplasia, which is, I think, is button nose and short neck. I'm not aware of it completely.
That's fine. Very good. But do they have scoliosis, or do they normally get another condition?
They got stenosis. Sorry, I take my word back. It is stenosis because of short pedicles.
Exactly. And not scoliosis. It's canal stenosis. Excellent. Excellent, Akka. Thank you very much. So like that, imagine that now you're shown a picture of a young child with trisomy 21. So what are you going to say? You're going to say this is a child with Downs. I do know it comes under chromosomal abnormalities of number. You can say the orthopedic manifestations. I would have asked someone, but just you should know there'll be slipped upper femoral epiphysis, patellar dislocation. So now Duchenne's. So you're going to say, I do know it's an X-linked recessive inheritance. I know it's due to protein dystrophin deficiency, and scoliosis is there as our orthopedic manifestation. And this is all what you need to know about genetics. I've given you just a few clinical scenarios, but now if you think of any other clinical scenario or a classical genetic condition, just put it there, know how to describe it as a classification. Second, know one orthopedic manifestation and try to know one more thing about it. That's the best way of studying this rather than just reading a chapter on it, because otherwise it's very difficult to retain. So thank you very much. Shwan and Firas, please add.
Thank you, Maxifar. I think that was excellent explanation of very complex subject. I think it draws the framework and people can start building into it. Can I say, just from the faculty, Shwan, we have also Hussam here. Shwan, do you have any comments? Anything to add, or you okay?
No, excellent presentation, very good framework for answering the questions. Some predicted ways that you could get asked this question is, for example, what is transcription, what is translation as described before? what is a chromosome, draw a chromosome, what's the difference between a pedigree chart and a Punnett chart, there was one more, sorry, what is an allele, what is those type of stuff. Describe the process by which you can transcribe DNA to proteins. How does it occur, and things like that. Okay, all of these questions are basic science, very straightforward to answer. Keep calm when you get hit with basic science. Trust me, guys, you know it very well. Just keep calm, take a deep breath, and answer. I thought you beautiful answer, man. But why did you say then I will look for rhizomelic or thing? Achondroplasia is dwarfism of what is it? Is it a normal spine or abnormal spine? Normal length of spine or abnormal?
The rhizomelic. It is a rhizomelic dwarfism. So you've got.
Why did you not just say that instead of making your answer very long and unnecessarily making me pay attention more to what you were about to say? You guys get that technique. Don't get yourself into trouble by being too smart, for want of a better way of saying it.
Yes. Yeah.
Simple.
That's good.
Move on to the question that actually matters, which is the second question in the exam. Okay, not the first.
Thank you, Shwan. We also have Hussam here. He's also one of our faculty members. He's joined tonight. Hussam, you have anything to add at the moment, or?
Hi, Hussam.
Hi guys. Hi, Mr. Maxwell. Sorry, I just joined, so I didn't join from the beginning.
That's fine. Well, just checking if you have anything. We have Fuad also. If I don't know if Fuad wants to add anything.
Hi, Fawz. Welcome.
No, again, I was just trying to set up the system, so I've just joined. Previously, I was not able to listen. Looking at the pictures, I think everything is fine. And
thank you. So, any other participant have any questions related to genetics in orthopedics? Please raise your hand, and I will let you speak to Mr. Maxima Vala directly. We have 5 minutes for questions. Just raise your hand on the chat option if you have any question, and I will connect you.
I would say that this is a good, try to keep it simple for these type of topics and make your own little charts. That's the only way I think you can get these points across.
Exactly. So I agree. Actually, the guys who know me know that I have this tiny little book where I'm drawing all of this stuff in. Do you see that? That's what I used to do for the exam. So if you draw that and label the stuff down there, and then you can actually expand it and connect it all to different stuff. This is no good to the guys who are sitting in February. I apologize. Guys who are sitting in April, this is what you should be doing, developing your step-by-step process. So, for example, right now, if someone says to you, give me the, could you tell me about Gaucher's disease? You talk about the inheritance pattern, the where it affects it. You've got the connections. You can then bring in the growth plate connection. You can bring in the inheritance pattern. You can bring in all the other stuff, even as your first sentence on this topic. This is why this topic should be easy for you guys, okay?
Yeah.
Bring that in as your first sentence. Where it affects the growth plate, inheritance pattern, and then that's it. You've got a relaxing sentence, and the examiners are already relaxed now. They know what you know the stuff. They're going to go about, well, tell me, how would you manage this patient?
Very correct. I think that's really right. Good.
That's great. Thank you. Thank you very much, Mr. Maxima Vala.
Thank you, everyone.
Yeah, finished. That's good.
Thank you.
Thanks everyone for joining. Thanks especially to Mr. Maxima Vala. We couldn't have anyone better than him to tackle this topic, and we're very happy that he is willing to support us within this group, and he will be hopefully giving us a lot more, many more lectures. All his lectures are excellent, so we'll let you all know about it in the future. We'll keep you all informed. Well, thank you very much, everyone.
Thank you very much. Thanks, Ron, and Firas and Fawad and Omar. Thank you again.
Thank you. I'll end the meeting now. Thank you very much, everyone. Bye-bye.